Hello, I'm Rena Buckstein. I'm a hematologist, a clinician investigator from Sunnybrook Health Sciences Centre in Toronto, Ontario. And I'm going to speak to you today about how we tailor our therapies to improve outcomes in myelodysplastic syndrome. So the first thing to talk about when we talk about outcomes are what are the important outcomes. And as a clinician, the outcomes that I value the most are, of course, overall survival, because this is a disease that shortens survival, leukemia-free survival, quality of life, and the components of quality of life, such as the symptoms of fatigue and dyspnea and physical functioning, as well as transfusion independence, the achievement of transfusion independence or the avoidance of transfusion independence. So how can we tailor our therapies to improve these outcomes? But before we talk about therapies, we actually need to talk about what other things need to be improved before we can treat the disease. And one of them is an improvement in the diagnosis. There are many elusive patients referred to us with idiopathic cytopenias for whom we suspect MDS, but whose bone marrows are not diagnostic. And it's emerging more and more that many of these patients with ICUS actually harbor somatic mutations seen in MDS. So they're now therefore called CCUS. And 20% of these ICUS patients harbor these highly specific pattern of mutations seen in MDS. And we're recognizing that 2/3 of patients with MDS and 1/3 of patients with CCUS have mutations that are would allow for some form of personalized therapy. So it's very important that we routinely do next generation sequencing in our patients, identify these mutations. It helps clarify diagnosis and prognosis, and may permit some personalization of therapy. With regards to refining prognosis, that was a good segue into prognosis. For us to decide on what therapies we're going to offer our patients that are hopefully personalized in the future, we need to identify who is at increased risk of imminently of leukemia or significantly shortened survival. And that we can do with our conventional prognostic scoring system, the IPSS-R or the WPSS as commonly used in Europe. However, we now recognize that that is still either overestimates or underestimates prognosis in anywhere from 20 to 30% of patients. And these same mutations that I alluded to that can be identified through next generation sequencing, these somatically acquired mutations, may help clarify prognosis that much more. And we are eagerly awaiting the results from the International Working Group Prognosis in Myelodysplastic Syndrome that's going to hopefully, with large data sets, incorporate somatic mutations into clarifying our prognosis. We can also clarify prognosis, and this was presented recently at ASH, using large data sets and machine learning algorithms, artificial intelligence, to come up with personalized prognostic scoring systems. And Aziz Naza from the Cleveland Clinic is sort of a pioneer in this area and has presented a number of times on this subject. And so I believe that once we assemble more and more data sets together, we will be able to personalize our prognosis even that much more. So talking about therapies to refine prognosis, to improve prognosis, there were a number of new therapies discussed at ASH that are showing a lot of promise. So the way we decide on treatment of lower risk MDS is based on symptoms, anemia being, of course, the most common finding, and symptomatic anemia being the most common symptom. And right now, our treatment algorithm includes erythropoietic stimulating agents. Unfortunately, only 50% of patients will respond to that. And if you're transfusion dependent, your likelihood of responding is even that much lower. We now have, fortunately, the availability of luspatercept for patients with MDS and ring sideroblasts. So we're here another example where we can personalize our therapy. If you fail an erythropoietic stimulating agent, and 38% of patients who are transfusion dependent who have ring sideroblasts will achieve a duration of transfusion independence of at least 8 weeks, and will have a meaningful reduction in their transfusion burden. We will have to await the results of the COMMAND study that is evaluating or comparing luspatercept versus erythropoietin as first-line therapy in MDS patients that are transfusion dependent. But we learned of a number of other promising agents that will hopefully allow us to improve anemia and reverse transfusion dependence in MDS patients. And these include drugs like imetelstat, which is a telomerase inhibitor, which looks particularly promising in the highest transfusion burden MDS patients, whereas luspatercept works a little bit better in patients with lesser transfusion burden. And another agent called roxadustat, which targets the HIF-1 alpha pathway and simulates hypoxia to increase erythropoietin and erythropoiesis. So we are seeing a lot of promise in the management of lower risk MDS patients with these two agents. Importantly, also at ASH, presented by the French group, was a study in which patients with del(5q) MDS who were transfusion independent were treated in a randomized control fashion between lenalidomide or placebo. And lenalidomide delayed time to transfusion dependence in the experimental arm. So speaking to my goal and objective to improve outcomes in MDS, which is to avoid transfusion dependence, this is certainly an effective therapy. It's been our practice in Canada to prescribe it not just for transfusion dependent patients, but anemic patients, pre-transfusion dependence. But in many parts of the world, I think it's only approved once you're transfusion dependent. So that was an important abstract that was presented. How do we refine our therapies in higher risk MDS patients where the primary objective is improvement in overall survival and leukemia-free survival, although the improvement in quality of life and transfusion independence are also important endpoints, but typically not the primary endpoints. And at American Society of Hematology meeting this year, we saw a significant flurry of clinical trials marrying novel agents with the hypomethylating agent backbone azacitidine. And as we all know, azacitidine is an effective agent. It has been shown in randomized trials to improve survival, but only for survivals of about 1.5 years. And in phase 1/2 studies, a number of new targeted agents are showing promise. These include things like venetoclax, magrolimab, which is an immune checkpoint inhibitor for macrophages, sabatolimab, which is an anti-TIM3 immune checkpoint inhibitor, APR-246, which is useful in patients who have a TP53 mutation, and pevonidistat, which appears to be particularly active in patients with higher risk MDS. So these phase 1/2 studies do seem to demonstrate higher response rates, higher complete remission rates. We will have to see what the randomized phase 3 studies reveal with regards to actually improving survival or leukemia-free survival, and hopefully with the interrogation of the baseline characteristics of these patients at a very high level and detailed level, we'll be able to better plan and personalize our combination approaches for MDS patients. For example, the use of magrolimab or APR-246 for patients who have TP53 mutated disease, and or pevonidistat for patients who tend to be higher risk. And finally, I see an improvement in the future of refining our prognostic tools. And finally, if we're going to improve therapy for MDS patients, we have to better refine our predictive tools. Predict who is more likely or less likely to respond so that we can avoid futility. And at the ASH meeting this year, Aziz Naza's group also presented a predictive model developed using machine learning algorithms and artificial intelligence to predict response to hypomethylating agents within 3 cycles, just based on changes in their blood count parameters. And so we need more and more of these predictive tools so that when we have a plethora of options available to us, we can identify who is more or less likely to respond to which agent and apply it accordingly. For example, knowing that someone has an IDH1 mutation, that they are more likely to benefit from a combination approach with an IDH1 inhibitor, and so forth. In my opinion, the future is very bright for MDS patients. I think in the next 5 years, we will have the emergence of new therapies, as we do now in AML, for treating our MDS patients, and that we'll be able to better personalize our treatments, better prognosticate our patients to identify those who should be candidates for more aggressive therapies or less aggressive therapies, and better predict who should be treated with what. And I thank you very much for your attention.